We're going to move now to a discussion, and folks are welcome to join us, but it's mainly for our affiliates. We welcome legislators, we welcome policymakers as well, as you hear from our regional policy representatives about things that have happened in the past year, what they're expecting going forward, and how you can help. It has really been my great honor to work with these wonderful people. I think it's been about 8 or 9 years now since I came to Mental Health America National, and I get to coordinate regularly and work with our regional policy representatives. Let me wait for everybody's face to come on here so I can introduce them. I see Shannah Mulvihill from our Mental Health America of Minnesota. Shannah is the executive director there, and we really appreciate her extreme knowledge about how to work with legislators and her leadership this past year when there have been so many difficult issues with respect to race and the lack of equity. So thank you, Shannah. We have Ben Harrington, who is the executive director of our Mental Health America of East Tennessee. And Ben is just phenomenal, as you will hear. Next to Ben, I see Moe Keller. And Moe is a former state legislator, and I love when everybody still calls her senator. In many ways, we'll always all think of her that way as a Colorado legislator. And where's Barb? Barb Johnston from our MHA of New Jersey. I don't see Barb back yet, but I'm sure Barb will be here. Barb is with our Mental Health America affiliate, the Mental Health Association in New Jersey. And Barb is really amazing in that the way the Regional Policy Council is structured, Barb has the most affiliates to work with. So we're really delighted that she's here. And I don't know if we had selected an order. Who would like to start today?
So Shannah Mulvihill with Mental Health Minnesota, and I guess I'm just going to share a couple of things that came to mind for me during today's meeting, and that is that I think a lot of us are looking at a lot of the same issues, and I think that's certainly something that we see in our work with our different clusters of states that we work with. There may be, pieces that are certainly unique about the way we do services and certain issues that come up. But overall, a lot of us are facing some of the same things. And so I think a lot of the attention right now is being paid to telehealth. And certainly that was a big point of most of the questions that came through in my breakout sessions. So thank you to Moe for being ready to answer all of those, because that really feels to me like kind of the biggest thing we all have to really work to sort out right now, because it's been a very quick change in the way we deliver services. While some of it was happening before, obviously it's been a really aggressive move toward almost exclusive telehealth for a lot of people, and particularly in mental health, that's a relatively new concept. So as we kind of wrap our heads around that and figure out the best way to make it work, I think it's opened up a lot of great access points. It has its challenges, certainly. It's not for everyone, but I think in terms of something that really we probably all have in common as affiliates and as states, is we're all kind of looking at telehealth as, how do we continue to make sure we're delivering services? How do we make sure it's good? How do we make sure it's working right for people? And what are some of the other issues that pop up, like access to the internet and how much audio only options play into that? And there's a lot of details there we need to pay attention to.
Debbie, I can follow up a little bit and add to what Shannah has been talking about. With regards to telehealth, we all kind of get real anxious at the end of a month right now, waiting for governors to extend telehealth through executive order because of the pandemic, and make sure that remains available. But it's not just telehealth in Medicaid programs and making sure reimbursements are equitable and stuff like that. That it's also on the other side of the aisle too in commercial insurance world too. We want to make sure that you know right now we have to have access to telehealth, but we certainly want that to continue even when we get past the pandemic emergency, because we have a ongoing access issue, and telehealth has not um, harmed that. Expanding telehealth has actually helped us some, so we want to continue that even well past the pandemic. Another issue I did want to address, though, and I, I, it dawned on me when we were in our breakout session that was focused on better budgeting before stage 4. you know, what states are doing that expand the opportunity for early intervention with kids through mental health education in schools, they're really addressing a huge equity issue. Because when if you don't have mental health education in schools, there's not really a lot of equity. Parents of means figure out their child might need help, and their child gets help. But parents without means may not be able to get help, because that means they've got to take time off from work, to be able to get their child to a doctor, that sort of thing. And so eventually, when you go from educating about mental health in schools, schools change their culture and they bring more mental health in. So it changes the whole equity landscape and provides um, mental health treatment in schools, so that now this is a whole lot more equitable for everybody. And that's something that I think we have to keep pushing long term, is more mental health education in schools, because of the benefits that can come for all persons. And so that was an important thing I got out of the breakout today, was to be able to keep reminding people of that. Uh, Mental health education in schools changes the equity landscape for everybody.
Well, in the breakout session that I was at with Shannah, we talked a lot about, we didn't use the term equity, but we talked about the difficulty some people have in accessing telehealth, at least the visual part, the video part, due to being in a rural area where there's not broadband or capacity, and even in some pockets of urban areas where people don't necessarily have that. However, the saving grace is that we do have um, audio, and so you could use your cell phone that way. But a couple questions came up that were very worthwhile in discussing. The first is that here in Colorado, our Medicaid office has expressed some concern of the situation where um, we now are seeing associations or networks of doctors who do technology services only. And so they might be a network provider that they're happy to do telehealth when they do, but if it comes a time when the individual who has a relationship with that person needs to visit in person, they can't offer that because they might be in Connecticut, or they might be in Virginia, or they might be in Florida, whatever. And so there's a break there. And what Medicaid is now trying to do is get ahead of that problem, potentially by requiring brick and mortar presence for telehealth professionals. But that's being toyed with. They haven't done that, but they're talking about that. We see that as an up and coming issue that we're going to have to look at, is how do we want to meet the telehealth demand, which has great promise, but then make sure that we can establish and keep and maintain a relationship with a provider when they're not in the state. So how we might want to handle that piece. And Ben, you look like you have a thought.
Yeah, Mo, I wanted to tag on to that
Yeah.
because the brick and mortar concept is a huge problem with regards to Medicaid, and serving kids in schools.
Mm,
A mental health center would like to do that and like to get reimbursed, but sometimes the Medicaid insurance companies are denying payment because that provider, that professional, is not licensed at the school address. So it's
that's
not a
exactly
brick
right.
and mortar address.
We've had the
It's
same thing.
yeah, and so the transition back to the telehealth is right now there are um, I want to say good partners in behavioral health services delivery that are providing telehealth, and they are working with professionals that have available hours and sessions, and they're plugging the round peg into the round hole to serve someone that can't get access, and that's fine. But if the Medicaid programs go back to the brick and mortar concept, we are going to have some big troubles with those that got served through the betterhelp.coms of the world, that
Mhm.
were using an
Mhm.
Indiana therapist that had
Right,
availability to help me in Tennessee. I mean,
right.
that's going to be problematic, as you say.
Well,
I'm jump in here for a minute for me. I'm sorry, Mo, to interrupt. I wanted to share with our participants two things that have just happened with respect to Medicaid that I think can make us all smile. One is that the Biden administration today announced that work requirements will not be happening for the states that have already had approval. They're rescinding that approval. They
really,
be doing any other states' approvals, and we'll see how that all unfolds, but that came out today. And the other piece of good news is regarding maternal mental health. In the COVID package that right now is moving, and it has just moved through markup in the Energy and Commerce Committee, and it still has in it expansion for 1 year postpartum, 1 year when a pregnancy ends, however the pregnancy ends for moms who are on Medicaid, to have continuous coverage under Medicaid. Now, it doesn't make it mandatory for states to do this, but it says, but what this says is that it will be very easy, and they don't have to have a waiver, they don't have to ask extra permission, they just have to say they want to do it. So we fully encourage them to do that. And we're running a few minutes over, and I wanted to have a final wrap up. I'm sorry Barb Johnston wasn't able to join us here at the end. She had some technical issues, but I just want to take 1 minute to reiterate that all of the information is linked on the page that you register. Oh, there's Barb. Hi, Barb. She made it back. I was just wrapping up. All of the information is on our MHA website. So you can see the model legislation, you can see our reports, you'll have the contact information for our regional policy representatives. And I want to just take 1 minute to thank our team. I want to thank our consultant, Amanda Adams-Barney. I want to thank Sachin Doshi, who has been behind the scenes helping us run everything and get past little glitches. I want to thank Maddie Reinhardt and Whitney Bell for helping us in our breakout rooms. I want to give a huge shout out to Karen Howard, with whom the meeting could not be done without all of her putting everything together and getting all the pieces together for us. Again, I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy. Oops, I missed Sydney. Sydney Giallo, who also is one of our behind the scenes folks. Sorry, Sid, when I can't see, I missed. I apologize. I'm happy to have any further questions. We're delighted that many representatives, legislators from all across the country, as well as people from the staff from mental health departments joined us. And you will be hearing from us with a video of the entire program without any of the glitches and all of the information. So again, thank you all for joining us, and a huge hug to our regional policy representatives, to Ben Harrington in Tennessee, Shannah Mulvihill in Minnesota, Barb Johnston in New Jersey, who came in late, and of course my fellow Coloradan, Moe Keller. So thank you all, and we look forward to joining you next time and next year in person. So thank you.